Hello there, my valued, highly treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services, so I humbly urge you to sit back and spare me part of your very precious time to share with you precious tips which you may find very handy and useful in your line of duty. So I welcome you to part 60 of our Pharmacotherapy MCQs series, which measures in Pulmonology. So my first question to you reads, what percentage change in the forced expiratory volume in 1 second, abbreviated as FEV1, is required for a short-acting bronchodilator to be considered a positive response or a beneficial response to a patient with asthma, to an asthmatic patient? Is it A, 2%, B, 12%, C, 5%, or is it D, 10%? I'll give you 10 seconds to choose the correct answer. So 12% it is. Now this is the criteria generally recognized as an indicator that the patient has reversible hyperactive airway disease that is responsive to bronchodilator therapy such as a beta-2 agonist, for example, salbutamol, levosalbutamol, or pybuterol. Now the change in FEV1 is determined by doing pulmonary function tests, what we abbreviate as PFTs, before the use of a short-acting bronchodilator, and then again after the use of the short-acting bronchodilator. I would just like to emphasize that this criteria mainly applies to in the context of treating asthma and not COPD, where there is very little bronchodilation after the administration of beta-2 agonists or even anticholinergic agents, due to the fact that damage has been done to airways in the case of COPD. That's just a by the way. Let's move to the next question, please. And it reads, Miss GWW, an 11-year-old female patient with a past medical history significant for an inadequately controlled asthma, presents to your clinic. She currently uses an inhaled steroid and an inhaled long-acting beta-2 agonist, what we abbreviate as a LABA. According to your chest physician, GWW needs additional therapy, and he goes ahead to initiate her on montelukast, singular to be specific. GWW's parents are present and they seek to know from your chest physician how they should give their daughter this new medication. So my question to you is, which of the statements listed below would best address this parent's question? Is it is best for her to take it twice daily? Or is it B, it is best for her to take it in the morning? Or is it C, she should take it in the evening since she has asthma? Or is it D, she should take it as needed when her symptoms seem to worsen? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. She should take it in the evening since she has asthma. Now, montelukast or singular is a leukotriene receptor antagonist that is indicated in the management of allergic rhinitis, of asthma, and even exercise-induced asthma. It is taken once daily, not BD, so that makes alternative A wrong. BD applies to other leukotriene antagonists such as zafilukast, for example, and it also applies to the 5-lipoxygenase enzyme inhibitors such as xylitol, if I remember well, which is marketed as Zyflo. So for montelukast, it should be an OD regimen, not a BD regimen. Now, if you are using montelukast for asthma, it is important to educate the caregiver that it should be taken in the evening to reduce the risks of nocturnal asthma symptoms, and any time of the day for those that are being managed for allergic rhinitis, for example. So in asthmatics, stick to the evening schedule or dosing. For allergic rhinitis, you can administer it at any time of the day. I would like to emphasize that montelukast, like other leukotriene receptor antagonists, is used for the prevention and should not be used in the acute management of asthma. Neither can it be used PRN. So let's move to the next question, please. And it reads, selected COPD patients may be treated with some antibiotics chronically to reduce the incidences of chronic obstructive pulmonary disease exacerbation. So my question to you is, which of the antibiotics listed below best meets this criterion? Is it amoxicillin, azithromycin, daptomycin, or clindamycin? I'll give you 10 seconds to choose the correct answer. Azithromycin it is. Now, azithromycin may be used in select chronic obstructive pulmonary disease patients who are prone to exacerbations with the aim of reducing the risks of exacerbations. Now, such patients can receive either 250 milligrams orally daily or 500 milligrams orally thrice weekly. Remember that. Now, clindamycin, on the other hand, shouldn't be used routinely in patients with COPD. It is inappropriate to use it, and it could significantly increase, for example, the risk of Clostridioides difficile infection. So avoid it. And daptomycin and amoxicillin are also not appropriate to be used long-term for COPD patients. All those many words make azithromycin the best choice in this particular case. Let's move to the next slide, please. And the question reads, which of the side effects listed below is the most likely to occur during the treatment of asthmatic patients with levosalbutamol? Is it hypotension, tachycardia, bradycardia, or hyperkalemia? I'll give you 10 seconds to choose the correct answer. So tachycardia it is. Now, although levosalbutamol is delivered topically by inhalation, part of the medication gets absorbed systemically because there is a small amount that is swallowed even as you inhale. Now, the other answers A, C, and D are the direct opposite to the common side effects of the short-acting beta agonist, what we call the SABAs. And I would like to add that there is a large misconception that levosalbutamol doesn't have the same side effects as salbutamol, or that it causes less tachycardia than generic racemic salbutamol. That is a misconception. Now, several well-designed prospective clinical trials have shown that levosalbutamol can cause the same, and in some cases even more, tachycardia or the other side effects as compared to generic salbutamol. Now, levosalbutamol and the regular racemic salbutamol are known to cause tachycardia. So all those many words make B the correct answer. Let's move to the next slide, please. And the question reads, which of the criteria listed below must chronic obstructive pulmonary disease patients meet in order for them to receive antibiotics for COPD exacerbations? Is it increase in dyspnea and sputum production? Is it an increase in sputum production and sputum purulence? Or is it an increase in dyspnea, sputum production and sputum purulence? Or is it the need to receive mechanical ventilation? I'll give you 10 seconds to choose the correct answer. Apart from answer A, the other C, B, and D are correct options. Now, patients with chronic obstructive pulmonary disease exacerbation should be given antibiotics if three cardinal symptoms, which are increase in dyspnea, sputum volume, or sputum purulence, are present. Antibiotics are also indicated for COPD exacerbation if two of the cardinal symptoms are present, as long as one of the two symptoms is increased purulence of the sputum. Remember that. Now, patients with COPD should also receive antibiotics if COPD exacerbation is so severe that mechanical ventilation is required. Now, if such patients reside in a nursing home with numerous exacerbations per year, Pseudomonas aeruginosa should be suspected and appropriately covered with the antibiotics, because they tend to be colonized by the Pseudomonas aeruginosa in such settings. Just remember that. Let's move to the next slide, please. And the question reads, Mr. DJT, a 67-year-old male patient, presents to your chest clinic with a past medical history significant for cardiovascular disease, a 30-year history of smoking, and you establish that he has retired from former employment and he previously worked at a sawmill for a total of 35 years. Today, his chief complaint is chronic shortness of breath, sputum production, and a cough. So my question to you is, which of the tests listed below should be conducted to screen this particular patient, DJT, for chronic obstructive pulmonary disease? Is it FEV1 less than 30% of the predicted value? Or is it an FEV1 to FCV ratio greater than 0.7? Or is it an FEV1 to FCV ratio less than 0.7%? Or is it FEV1 less than 30 to 50% of the predicted value? I'll give you 10 seconds to choose the correct answer. So C would be the correct answer in this particular question. Remember, Mr. DJT has numerous risk factors for chronic obstructive pulmonary disease and therefore requires spirometry testing. Now, in the context of his history, symptoms, and spirometry, an FEV1 to FCV ratio below 0.7 is diagnostic for chronic obstructive pulmonary disease. Now, a post-bronchodilator FEV1 of 30 to 50% of the predicted value is a staging criteria for COPD. Now, patients with these findings are in gold class 3, which is severe, considered severe in the COPD staging. Now, patients with an FEV1 less than 30% of the predicted value are in gold class 4, which are considered very severe COPD cases. I would like to remind you that Mr. DJT's history of smoking, cardiovascular disease, and the occupational exposure to particulate organic dust for over 35 years increases his risk for chronic lung disease. Remember that. Now, for patients undergoing post-bronchodilator FEV1 testing, FEV1 should be measured 10 to 15 minutes after a SABA, short-acting beta-agonist agent, is administered, and then 30 to 45 minutes after a SAMA agent is administered. Those are small bits of information that you need to pay attention to when carrying out those tests. Let's move to the next question, please. And it reads, select the statement below which best describes the mechanism of action for riociguat. Is it is a phosphodiesterase 5 inhibitor, or is it an endothelin receptor antagonist, or is it a stimulator of soluble guanylate cyclase, or is it a prostacyclin vasodilator? I'll give you 10 seconds to choose the correct answer. C is the correct answer. Riociguat, which is commonly marketed as Adempas, is a stimulator of soluble guanylate cyclase, which is abbreviated as small s, capital G, and capital C. And that is an enzyme in the cardiopulmonary system, to be specific. Now, an example of an endothelin receptor antagonist is ambrisentan, marketed as Letairis, if I remember well. And it's used in the management or the treatment of pulmonary arterial hypertension. Now, an example of a prostacyclin vasodilator is epoprostenol, which is marketed as Flolan, and this particular agent causes direct vasodilation of pulmonary and systemic arteriovascular beds, and it also inhibits platelet aggregation. It is available as an IV infusion, which is administered by a CVC. So for those in clinical practice, do not administer this agent peripherally. Ensure there's a CVC line before infusing it, and never administer it via bolus. Remember those small tips that may improve clinical outcomes. Now, an example of a phosphodiesterase, or examples of phosphodiesterase 5 inhibitors include avanafil, marketed as Stendra, sildenafil, which is marketed as either Viagra or Rivatio, and tadalafil, which is marketed as Cialis, and the last one I know of is vardenafil, which is marketed as either Levitra or Staxyn, Staxyn. I would like to underscore the fact that riociguat or Adempas is approved for chronic thromboembolic pulmonary hypertension, which is abbreviated in literature as CTEPH. And it can also be used for pulmonary arterial hypertension. Let's move to the next question, please. The next question reads, as a clinical pharmacist in your chest clinic, you have been tasked to do medication use counseling for all patients scheduled for appointments today. My question to you is, which of the following teaching points would be the most appropriate for a patient with chronic obstructive pulmonary disease? Would you advise them to prime the dry powder inhaler, what we abbreviate as DPI, prior to the first use? Or would you advise them to prime the nebulizer prior to each use? Or would you advise them to prime the metered dose inhaler, the MDI, prior to the first use? Or would you advise them to prime the metered dose inhaler prior to each use? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. I would advise such a patient to prime the metered dose inhaler prior to the first use only. Now, for patients using a metered dose inhaler, they should be instructed to prime the device prior to the first use. Appropriate instructions include, for example, insert the canister into a plastic actuator body, then shake well and remove the mouthpiece cover. Remember, it's not obvious. Some patients may administer the drug without removing the mouthpiece. Now, when priming the device, the canister should be actuated, that is, pressed into the plastic body, and that should be done twice to release 2 doses into the air to remove any airlock that may be existing. Now, I would like to emphasize that nebulizers don't require priming before use. However, they can be technically challenging to correctly assemble or set up before use. So you have to teach patients who need them at home properly and thoroughly on how to assemble and use them. Dry powdered inhalers, on the other hand, don't require any priming before use. So don't advise them to do so, to prime them. It will be a waste of doses. And then I would like to re-emphasize that metered dose inhalers should be primed prior to the first use, not prior to every use. That would also amount to wastage of those very valuable medications. Let's move to the next slide, please. And the next question reads, Miss G.O.S, a 15-year-old adolescent female, presents to your chest clinic with a chief complaint of wheezing and shortness of breath related to her asthma diagnosis. And due to her symptoms, she wakes up 2 to 3 times weekly. Now, she has been using her relief inhaler more than 3 to 4 times weekly during the day. Her salbutamol inhaler technique appears to be appropriate. When you ask her to teach back, she demonstrates competence, and she informs the chest physician that she has been avoiding her known triggers. She was thoroughly educated on the triggers, and she avoids them. So my question to you is, which of the following would be the next best step-up treatment for Ms. G.O.S to ensure her asthma is brought under control? Would it be the addition of a controller with a long-acting beta agonist only, a LABA? Or would it be the addition of a controller with a low-dose inhaled corticosteroid, the ICS only? Or would it be the addition of a reliever with a long-acting beta agonist only, a LABA? Or would it be the addition of a reliever with a low-dose inhaled corticosteroid, an ICS only? I'll give you 10 seconds to choose the correct answer. B, the addition of a controller with a low dose inhaled corticosteroid only. Now, the GINA guidelines no longer recommend starting with a short-acting beta agonist only treatment. I would recommend you read them, the updated ones. The current recommendation is that all adults and adolescents with asthma receive inhaled corticosteroids, what we abbreviate as ICS, containing controller treatment in order to reduce their risks of exacerbation and to control the asthma symptoms. Now, low-dose ICS is shown to be effective for initial dosing in such patients. Now, long-acting beta agonist, what we abbreviate as a LABA, may be used as a reliever or a controller therapy along with an ICS. We see a lot of this in practice currently. Now, currently the only LABA-ICS combination with supporting evidence is the budesonide formoterol combination. And I would like to emphasize that there is no evidence or recommendation to support adding an ICS only therapy for symptom relief. Now, the GINA guidelines, the same GINA guidelines I referred to earlier, recommend that all adults and adolescents with asthma should receive ICS containing controller treatment if they are to receive short-acting beta agonists for PRN use. So I would refer you to the same guidelines to read and digest that well. I would like to just mention as a by the way that a 64% reduction in severe exacerbation was found in GINA Step 2 study with a PRN low-dose budesonide combined with the formoterol as compared to a SABA-only option. So all those many words justify why alternative B would be the correct answer. I would recommend adding a controller with a low-dose inhaled corticosteroid. Let's move to the next question, please. And the next question reads, KLM, a 10-year-old Ugandan female with a past medical history significant for allergic rhinitis, which is managed by the use of OTC fexofenadine, is thoroughly examined by your chest physician who diagnoses moderate persistent asthma, for which she is currently treatment naive. She's not received any asthma treatment at all up to now. So my question to you is, which of the regimens listed below would be the most appropriate for KLM? Would it be theophylline? Would it be a medium dose inhaled corticosteroid? Would it be a long-acting beta agonist, a LABA? Or would you opt for chromonil, sodium chromoglycate? I'll give you 10 seconds to choose the correct answer. Settle for a medium dose inhaled corticosteroid, an ICS. Now, based on the NHLBI guidelines, that abbreviation stands for National Heart, Lung and Blood Institute. Based on their guidelines, in children aged between the age of 5 and 11 years, a medium dose inhaled corticosteroid is the only appropriate choice. Remember that, and I would refer you to those guidelines. Google them and read them. Now, the other three options are appropriate when combined with a low-dose ICS in step 3 to be specific. Now, the patient should also receive a quick relief inhaler for rescue, and an optimal choice would, for example, be salbutamol administered PRN. Now, consideration for the use of a short-acting or a short course of oral corticosteroid may be deemed fit if necessary. Yeah, there are clinicians who opt to give prednisolone orally, briefly. That's just a by the way. Let's move to the next question, please. And it reads, Mr. TMK, a 20-year-old patient of male gender without a significant past medical history, presents to your chest clinic for a workup of coughing and wheezing during his rugby practices. He informs your chest physician that at daily practice, which he does 6 days in a week, he experiences difficulty inhaling deeply, in his own words, and that is associated with wheezing. And according to him, this is accompanied by a coughing spell, in his own words, which persists till he sits down and rests for, in his own words, a couple of minutes. He denies having the same episodes at other times of the day, but admits waking up at night coughing about 2 times in a week. Now, after ruling out other causes, the chest physician diagnoses TMK with asthma. So my question to you is, which of the following statements regarding TMK is the most appropriate? Is it, he has moderate persistent asthma, therefore we should start medium dose corticosteroid and PRN short-acting beta-agonist, SABA? Or is it, he has mild persistent asthma, so we should start a low-dose corticosteroid and a PRN SABA? Or he has moderate persistent asthma, so we should start high-dose corticosteroid and a PRN LABA, long-acting beta-2 agonist, and a PRN SABA. Or he has severe persistent asthma, so we should start high-dose corticosteroid and a PRN LABA and a PRN SABA. So I'll give you 10 seconds to read through those many words and choose the correct answer. So A is the correct answer. This is a case of moderate persistent asthma, and it's recommended we start a medium dose corticosteroid and a PRN short-acting beta-agonist, SABA. Now, based on the National Heart, Lung and Blood Institute's asthma guidelines, TMK is classified as having moderate persistent asthma based on essentially daily symptoms and greater than 1 nighttime awakenings, but less than every night. Remember, it doesn't occur every night, but it's more than once in a week. Now, appropriate initial options for moderate persistent asthma include low dose ICS plus LABA or medium dose ICS. And I'd like to add that all patients should receive a short-acting beta-2 agonist as a quick relief option, as a rescue inhaler, and salbutamol would be a suitable choice here. Now, in this particular case, this patient may need future prophylactic SABA therapy prior to exercise, his rugby practice, to minimize what may be exercise-induced bronchospasms. But given the frequency of the symptoms and the nighttime awakenings, long-time controller, in my opinion, may also seem appropriate to avoid those many nighttime awakenings. So, my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, please remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel, and I promise you that the best is yet to come. Thank you very much for viewing it and for listening to me. I sincerely appreciate your partnership and your continued support and kind collaboration. So I look forward to interacting with you in the next video, which will be part 61 of our pharmacotherapy MCQ series. So thank you.